iris claw lens works in the person's eye?
Pupillary spotted lenses, angle spotted lenses, Pannu lens. They were very big size lenses and they caused lot of erosion in the eye. The iris tissue has a love affair or affinity for the angle, and the angle has a affinity or a love affair for the iris.
What are the dimensions of the IOL?
So it is basically a round shaped four claw lens. The optic is 3.5 millimeters and rest is the four claws. Overall diameter is 5 millimeters.
Okay.
So I've been seeing iris claw lenses for the last 30-40 years, doing them. So it is my blood, it is my genes, how to handle the iris, how to handle the iris claw lens.
How can manufacturers and doctors collaborate to make these innovations successful in future?
They will make everything what you wish.
Welcome to DocPod. Here we will have discussions on research and latest advancement in medicine and science.
In today's episode of DocPod, today we have invited Dr. Kiranjit Singh from Amritsar. He is not only a doctor but he is also an innovator. In 2011, he innovated that ovulated rexes, which is now known as Dr. Singh's rexes. In 2020, he invented or he enhanced the iris claw lens, which is now known as a novel point 4 claw iris fixated IOL. As an innovator, he is following his father's footsteps, who is Dr. Kiranjit Singh from Amritsar. He is a Padma Shri awardee and he was the founder of Dr. Kiranjit Singh Eye Hospitals. Now Dr. Kiranjit Singh and his brother Dr. Ravijit Singh both are managing Dr. Kiranjit Singh Eye Hospital, which is located in Amritsar. Now let's welcome him. Hello sir.
Hello.
First of all, welcome to the show.
Thank
And
you.
Thank you for accepting my invitation.
My pleasure.
I'm feeling very honored that you are sitting in front of me. So today we are going to have a discussion on something called innovation. It's a subject, it is very untouched in India, and you are the example of that innovation in ophthalmology. So first of all, I want to ask you, what's the inspiration behind becoming the ophthalmologist?
Actually, I wanted to be a sportsman, but my father had different dreams about me. So the very day I finished my MBBS, I was so relieved. I felt like sleeping till late afternoon. But in the morning, 4 o'clock, my father came and threw a mug of water on me. And he told me, let us go to the hospital. So from that day onwards, I've been running till date. So this is a story, and there is no inspiration. It is basically compulsion. But now compulsion has converted into passion. Yeah.
So sir, you play golf also.
Yeah.
So how do you manage like golf with ophthalmology?
So basically, we have to innovate so many shots in golf. Sometimes you are at the edge of a sand bunker, edge of a water body, or in the bushes. Then you have to innovate shots. And when you have an innovative mind, you can apply it on the field you are in.
Yeah, exactly, sir. Exactly. So, sir, even your father, late Padma Shri Dr. Daljit Singh, sir, even he had that innovative mindset also. Like he invented that iris claw lens. Am I right?
Yeah. So it is, I think, only his genes who are working through me. And it is only because of those genes I have modified the iris claw lens into a 4 claw iris claw lens. Actually, the whole credit goes to Dr. Jan Wurst from Holland, who created the idea of iris claw lens. And then the credit goes to Dr. Daljit Singh for propagating that idea.
Okay.
So there were some flaws in that IOL, which I have tried to rectify as far as difficult cases or complicated cases are concerned. So it is inspiration from both of them.
Okay. So, sir, can you describe me like how iris claw lens works in the person's eye?
So in those times, the concept of putting a lens in the bag was not there. So that time we had lenses like uh, pupillary supported lenses, angle supported lenses, Pannu lens, and they were very big size lenses, and they caused a lot of erosion in the eye, causing UGS syndrome. U for uveitis, G for glaucoma, and H for hyphema. So this is the only lens which has stood the test of time. And we still have patients coming operated 45 years back and with lot of RS tissue in the claw, stable lenses, and they are having endothelial count of 2000. And as far as its compatibility with the RS tissue is concerned, it is undoubtedly very good.
Okay.
And people are usually talking about its association with cystoid macular edema. I think that is not true because there are so many other reasons like diabetes, like uh, hypertension, uveitis, which can be cause of cystoid macular edema. And of course, the bigger sized iris claw lenses, they do have some affinity to cause some kind of endothelial damage in the long run. But the lens which can sustain, or you can take it otherwise, the eye which can sustain in the presence of a iris claw lens for the next 15 to 20 years, that means that lens must be having something good in it. And if some complications are occurring, that means we have to study or revisit the design and make it more inert.
Okay. So, sir, that's the progress towards that glucoclaw lens.
No. This 4 claw or glucoclaw, I have reserved those lenses for difficult cases
Okay.
where they are refused surgery everywhere. And but if a lens is not good, the eye will not survive more than 3 months. So you have to take positives from iris claw lens rather than talking just about corneal damage which has occurred because of its primitive design or some flaws in the design.
So, sir, as we were talking about this new enhancement which you have done in iris claw lens, it is novel 4 claw iris fixated IOL.
Modification.
Yeah. So, sir, what it is like, how it looks and how it works in the patient's eye.
So you see, if the patient is normal, then I'll go for a posterior chamber lens in the bag. And suppose there is something wrong with the posterior capsule, I'll do a ciliary fixation that is in the sulcus with optic capture. But if the case is complicated, like you have a patient of therapeutic grafting done for fungal ulcer or for corneal ulcer, where after you have done the therapeutic grafting, there are chances of leakage of aqueous, and then you have chances of synechia formation in the angle. It is those eyes in which this lens is applicable to, where I want to pull the iris from the angle so that the synechia, they don't reform. So you see, what I have gathered in the last few years is, like a girl has affinity for boy and a boy has natural affinity for a girl, vice versa.
Yeah.
Similarly, the RS tissue has a love affair or a affinity for the angle, and the angle has an affinity or a love affair for the iris.
Iris.
So if it is loose, the pupil is not reacting. It is lax. It is ultimately going to go out towards the angle and cause angle closure glaucoma or synovial angle closure glaucoma.
Glaucoma.
So it has to be pulled inwards, the pupil. And one of the greatest inventions has been done by Dr. Amar Agarwal. He has started doing a pinhole pupilloplasty. So where he applies suture to the dilated pupil, he sutures it in 2 or 3 places, and the pupil becomes small. And so when the pupil becomes small, there are chances the angle also opens up. And when the angle opens up, it does start to function.
Okay.
So the glaucoma books say that if the angle is fibrosed or this and that, it will not function. But at least by doing a pinhole pupilloplasty, we are trying to maintain the anatomy of the eye, trying to reestablish the anatomy of the eye. So we are making the pupil small. That is a very big thing.
Okay.
And this 4-claw lens, it is also doing the same job.
Same job. Okay.
The only benefit this lens has, so it has multiple functions. Firstly, it is going to correct the aphakia part. I'm talking of complicated cases. So it has cured the aphakia part. Then when I enclave the iris, I first do some goniosynecholasis. And if I don't do anything, those synechias are going to reform again. And this time, their adhesions are going to be stronger than before. So when I enclave the iris, I enclave the slightly peripheral part of the iris into the claw, so that there is a pull which is created at the angle.
Okay.
And because I have been dealing with iris claw lens for the last 35 years, I know how much to pull from the angle.
Okay.
Because if I do a gross movement of the iris into the claw, I am going to pull the iris root so much that it can cause bleeding, which will not stop.
Okay.
So you have to be very careful how much amount of iris you have to enclave
In that lens.
in that claw
In that claw.
at 4 points. Basically, it is a superficial surface. You have to wrap around a 26 gauge needle or a cannula, and along with the cannula, that iris goes through the claw.
So, sir, what are the main complications of glaucoma after therapeutic grafting?
I have told you earlier also, when we do therapeutic grafting to save the eye, you may you may do very good suturing, but still there will be leakage because the host cornea is edematous, and if you apply the sutures even very nicely, the leakage is going to occur. And when the leakage is going to occur, the chamber is going to get shallow, and that is the time when anterior synechia between the cornea and the iris, they are going to form and cause synechial angle closure.
Okay.
And I did 2 cases, I published them also. One was a 45-year-old man, and other was a 16 to 17 years old boy. Both had fungal corneal ulcer. After therapeutic grafting, the infection was eradicated, but the IOP was around 40 with all anti-glaucoma medicines with Diamox. But when I did the goniosynecholasis and I enclaved and I fixed the iris claw lens at 4 places, presently both the patients are at 16 and 19 respectively, without any glaucoma medicines.
Okay.
And it has been now 2 years. They are going stable.
Okay. So, sir, like, what are the dimensions of the IOL?
So it is basically a round shaped 4-claw lens. The optic is 3.5 millimeters and rest is the 4 claws. Overall diameter is 5 millimeters.
Okay.
And but
So-
you can custom make these lenses for different patients.
Okay.
If the eye is small, you can make it 4 millimeters in a microcornea.
That optic.
Yeah.
Okay.
No, overall.
Overall.
So if you want to make a big lens, that is your wish.
Okay.
But for that, you will have to make a bigger incision and apply sutures. But if you are used to making a tunnel, scleral tunnel, then you can always go in with a bigger lens also.
Okay.
And if the lens is attached at 4 places to the interior surface of the cornea, to the interior surface of the iris, it will do no damage to the cornea.
Cornea.
Yeah.
So, sir, there must be a limitation or a learning curve for this IOL.
Yeah, definitely it has a learning curve because I have been seeing it for the last 40 years. It is in my genes, and I was born in an era when iris claw lenses were used in our hospital, and the number of cases we had in our hospital were around 90, 100 every day. So I've been seeing iris claw lenses for the last 30, 40 years, doing them. So it is my blood, it is in my genes, how to handle the iris, how to handle the iris claw lens. But I must say, there is a learning curve. Suppose somebody tells me to do a glued lens, I won't be able to do. Because I have to go through that strenuous hard work to learn how to do a glued lens. Moreover, glued lens or SFIUL, it is easier for a VR surgeon, not for an anterior segment surgeon. Because they are used to dealing with the vitreous retina and dealing with complications. But if an anterior segment does glued lens or SFIUL, then he may harm the eye more than doing good to it. But you see, if one human being can do one thing, the other can also do.
Yes, exactly.
So I am sending my surgeries to different WhatsApp groups. I'm just trying to ignite the fire. And if somebody wants to learn this lens, I'm ready to
Teach that
Yeah.
ophthalmology. Sir, how effective is this 4-claw iris fixated IOL is maintaining stability in patients with aphakia?
You see, when you have aphakia and you don't have when you have a posterior capsule intact, then you are supposed to put the lens in the bag or in the ciliary sulcus. But when the capsular bag is compromised or deficient, then no lens can be put behind the iris supported by the remnants or the capsular bag. So the best place I find to implant the lens is the interior surface of the lens. So it is not only doing one job, it is doing multiple jobs. I'm talking of 4-claw lens. So firstly, it is correcting the aphakia. Then it is pulling the iris from the angle and breaking the synechia. So when we break the synechia, the interior chamber also deepens. Number 4, if there is some amount of glaucoma, that will also get treated, or that will help to control the pressure, the IOP, along with the medicine. So it will definitely help. And number 5 is the pupilloplasty. Automatically, when you are pulling the iris inwards in the claws, you will be doing a pupilloplasty as well.
Exactly, sir.
The same way Dr. Amar Agarwal's pinhole pupilloplasty is doing, similarly, I'm able to do some amount of pupilloplasty
With that lens.
with the 4-point fixation.
Okay. Sir, is there any post-operative complications with this lens?
Yeah. I'll tell you about a story. The story goes like this. So a patient came to me with an angle supported lens. He got it done in a railway hospital. So it was touching the cornea. So I removed the angle supported lens, did the vitrectomy part, and put a iris claw lens. And I could maintain a good vision of 6 by 6 or 6 by 9 with the help of glycerin drops for the next 6 months. After that, the patient vanished. He came to me after 2 years and there was no lens in the eye. So I was quite furious with him. So I asked him, where is the lens? So he said, you are mentioning to me that you may require a DSEC in the future. So I took another opinion from a Dr. B. So when I went there, he told me, you have a corneal problem and this is because of the iris claw lens. So I'm going to take it out. So he took it out. The Dr. B took it out. While he was taking out, also came the vitreous and the iris into the wound. So there were so many anterior synechiae and the eye became from bad, it became to worse. So then he went to a Dr. C. So he told him, you have to go to a corneal surgeon, that is Dr. D. So from Dr. C, he went to Dr. D. So the Dr. D told him, until and unless there is a support in the pupillary area, like a iris claw lens, I cannot do a DSEC. So you have to go to the doctor who exchanged the angle supported lens, that is me, Dr. A. So again, he came back to me. So I had a talk with Dr. D, who had told him to get iris claw again. So he said, I told him I'll do a iris claw lens. So he told me, whatever you do, those synechiae are going to form again. And he is ultimately going to get blind in that eye due to glaucoma. So I told him, don't worry, I'll fix in such a way that all the iris tissue responsible for the anterior synechiae, I am going to separate them. After doing vitrectomy, I am going to enclave that only iris, atonic iris, into the claws. A lot of tissue into the claws, 2 claws at 2 places. So after I had done it was a blind surgery. There was no visibility. And then that patient went to the Dr. D, got a DSEC done, and now he can read 2 lines. So from that day onwards, I started thinking, if the patient has got anterior synechiae and we are unable to control the IOP with medicines, this lens can be used to treat glaucoma also. So then I ordered lenses with no optic, but with 6 claws. So I ordered it, and then came a patient to me from Rajouri district. So he had got a IOL surgery done 2 years back, but for the last 6 months, he was having high IOP, means high intraocular pressure. And IOP was ranging from 40 to 50 with all medicines, Diamox and Mannitol also, occasionally. So I opened up the eye and initially I did a YAG PI, but that did not bring the IOP down. So I posted him for surgery. I did a PI and I opened the pupil with iris hooks, and there were a lot of leathery membranes behind the pupil. I had to cut them with scissors, and I'm talking 7 years back. So all the leathery adhesion I broke or cut with the scissors, and there was a lot of fibrin and blood and whatnot in the anterior chamber. I fixed that six clawed lens in the eye without an optic.
Without an optic.
And I closed the eye. And the first thing I told my assistant was to delete the recording. So I got it deleted because I had performed so horribly bad that I never wanted to see the movie again. So the patient went back and he gave me his phone number also. So I kept asking him, "How are you feeling?" He said, "I'm fine, I'm fine. My pressure is okay." And but I could not believe my ears that he's okay because I had done too much on his eye. And he came with the endothelial cell count of, I think, 900 or so. So last month he came from Rajouri again and I got his IOP checked. It was 16 and his vision was 6 by 6 uncorrected. It is 7 years follow-up. And today I repent, why did I delete the movie?
That recording. So what are the biomechanical interactions between the iris claw fixated lens and the iris tissue? And how do they influence that stability and iris health?
So I'll answer it in my own way. So you have an iris, interior surface is just muscles, but the posterior surface has got very sensitive things. Posterior surface, back of the iris. I feel the interior surface is very inert. And people talk of iris atrophy. When you enclave the iris, make it go through the the claw of the iris claw lens, they coin a term called iris atrophy. That is a wrong word. Actually, it is iris depigmentation. When you go through the claw, some depigmentation happens, but it is not iris atrophy. But of course, if you enclave very little amount of iris in the claw, it is going to give away in a decade or so. So interior surface is very safe for the enclavation of 2 claw or 4 claw.
Okay.
And when you have an eye where there is no posterior capsule, then there is iridodonesis because there is no support. There is vitreous and then there is iris. And when you implant a lens, whether it is 2 claw or 4 claw, it is going to exhibit little amount of pseudophacodonesis. I have seen few cases of SFIOL where the SFIOL is fixed to the sclera very nicely, but still the patient has got iridodonesis. So that amount of iridodonesis is going to be there. And there is one more important thing I want to touch. The back surface of the iris. If you just throw the lens behind the iris in one way or the other, and it is that lens PCIOL is at an angle to the posterior pigment epithelium, there is going to be rubbing, like windshield wiper syndrome, where the edge of the PCIOL is going to rub against the posterior pigment epithelium, even if the lens is very smooth. But the edge is going to do some erosion, and that erosion causes dislodgement of the posterior pigment epithelium, which is black in color, and that is what is responsible for pigmentary glaucoma.
Okay.
Whatever sheds from the interior surface of the iris while enclaving, that is washed away during the end of the surgery. And that cannot be the reason behind pigmentary glaucoma. It is the pigment from behind. And when we implant a 2 claw iris claw lens behind the iris, that 2 claw iris claw lens becomes a part of the iris. So there is no point of friction happening between the two.
Yeah.
But if it is a PCIOL, it is implanted at an angle. It is going to cause erosion. So I have few videos to show that there was a case, the patient was having 6/6 vision, Magello cornea, and the patient had put a PCIOL once, twice, thrice, and every time the lens would become a wandering lens behind the iris, and that patient was having 6/6 vision, but his IOP was increasing day by day. And the cause was pigment release from the posterior pigment epithelium into the anterior chamber, which was getting lodged in the trabecular meshwork. So I took out that lens, washed out large amount of pigment epithelium lying at 6 o'clock in the anterior chamber, and put a 4-claw lens, and his IOP started to become normal.
Okay.
Initially with the medicines, and ultimately he may not be needing anti-glaucoma drugs.
Sir, how does the material of iris fixated 4-claw IOL helps in influence its biocompatibility, particularly in preventing inflammation and pigment dispersion?
I have talked about the pigment dispersion, and regarding biocompatibility, in World War II, the cockpits of the aeroplane, fighter planes, were made up of this acrylic. When the bullets used to hit the cockpit, that acrylic used to go into the eyes of the pilots. But they found there was no reaction in the eye. So that is why this material has been adopted for intraocular lens manufacturing. So there is no point of talking about biocompatibility because it is biocompatible.
It is already biocompatible, that
Yeah.
PMMA material.
Yeah, it is friendly to the eye.
Sir, in preventing that inflammation, koi lena dena?
Inflammation will not happen uh, if your surgery is clean.
Okay.
Inflammation will only happen when your surgery is not clean.
So, sir, it depends upon the surgery.
Surgery. Yeah.
Sir, what is that impact of 4-claw on anterior segment dynamics?
So I will come up with examples. Ultimately, we'll incorporate the movie with uh, uh, incorporate some movies in this interview. Otherwise, it is going to be lifeless. So there was a lady who came from Jammu and Kashmir. Her IOP was increasing day by day, and there was Sainike all around the place. So there was an angle supported lens, half in the posterior chamber, half in the anterior chamber, and there was no vision, and the ultimate fate of that eye would have been it would have gone blind. So I have the habit of touching such eyes after taking consent from the patient, and usually in most of the cases I am doing free surgery. So I took the angle supported lens out, did vitrectomy. They were anterior synechia, and I cut them with the Vanna scissors, and I implanted a 5-claw iris claw lens with a optic. And from no vision, now she has 6/18 vision, means she can read 4 lines. And IOP was 29 with all medicines, but presently the IOP is 19 without medicines.
Okay. Sir, even you have invented that ovulated rexes also, which is famous by the name of Dr. Singh's rexes.
Yeah.
So, sir, tell me about that.
Actually, I have inherited the genes of um, doing something unconventional from my father. So I have been listening to the lectures by so many doctors who advise to do a smaller rexes instead of the normal rexes, because they are always thinking smaller rexes in cases of posterior polar cataract, where the posterior capsule can be deficient or weak, so they advise to make it smaller from the normal routine regular axis. Keeping in mind that if something goes wrong with the posterior capsule, they would be doing a ciliary sulcus supported posterior chamber lens, and they will do a optic capture in that small CCC. But our main aim is to take out the nucleus. For that, we need a bigger axis. But the disadvantage of a bigger axis is, if we have to implant a ciliary supported PCIOL 3-piece lens, then we cannot encapture that lens in the anterior opening because the opening is very big. We cannot capture the lens. So that gave me an idea to make a hybrid. Like you have hybrid vehicles, petrol plus battery, diesel plus battery. Similarly, this oval axis is a hybrid of a bigger and a smaller axis. It has advantages of both small and bigger axis.
Okay.
For taking out the nucleus out from the capsule bag into the anterior chamber, you have a bigger axis. But if you want to capture the optic of the PCIOL, you have a shorter axis. So it is giving me very good results. I have been able to convince few people, and it is getting popular at a snail's pace. Let it be.
Yeah.
And number two, this oval axis, it helps me in black cataracts.
Okay.
So instead of doing a small axis and then struggling, I make a very long oval axis, make very long and deep gutters, craters in the black cataract, then rotate the cataract at right angles, again make very deep long gutters or craters, break the lens into 4 pieces, emulsify them, put the lens in the capsular bag, then I cut the narrow axis on both sides with the help of Vana scissors and also make it very big.
Okay.
So now you have a very big axis with a PCIOL in the bag. And with this, you can save so many posterior capsules and you can save endothelial cells also.
So now let's conclude this. My last question would be ki, like, how can manufacturers and doctors collaborate to make these innovations successful in future?
You see, these manufacturers have a great role in development. And whatever idea doctor gets, he should talk. He should talk it out, talk his heart out on the phone or personally. He should tell him what he wants. And these days you have computerized everything. They will make everything what you wish to get it made. And if you are a regular user of their lens, they'll do it happily. It is not going to cost them much. So it is a win-win situation for both of you.
Yeah.
So whatever idea you get, you should share it with the manufacturer.
Sir, thank you so much for being on the episode. It was my honor to have you.
Thank you.